Very good morning to all of you. Today being the last day, I think we have very in our attendance. I am Dr. Jignesh Taswala, the chairperson. With us, I have the convener, Dr. Shweta, and Dr. Arvind Maurya, the moderator. We'll start the first lecture. Already we are running short of time. Challenging cases in cataract. Dr. Rupa Kumar, is he there? Yeah, please. Arvind, you would like to finish and go what? Okay. You are number 7. Okay, fine. Yes, Dr. Rupak.
A very good morning to you all. I would like to thank AOS for giving me this opportunity to speak to you about a series of challenging cases in cataract surgery. I would like to present the first case. The case 1 is a 60-year-old female person with NS2 cataract, planned for phacoemulsification with IOL, implantation of a 22.5 diopter VVT IOL. So case went uneventfully. Very slow injection of the VVT IOL. It was a straight shooter and then bang. So the shooter messed up and it released fast, and the lens was released into the bag. As you know, there's a small PCR. Pointer, please. Pointer. There's a small PCR, and the leading haptic had opened into the vitreous cavity. I was quick enough to rotate the IOL and bring it back into the bag. And the trailing haptic I have tucked into the bag and slowly rotate the IOL and kept everything in position. So after this maneuver, I found out that there is no vitreous in the anterior chamber. And then I went ahead with the irrigation aspiration and slowly completed the irrigation aspiration. You can still note the small PCR being there, but there's no vitreous disturbance. So I closed the incision and completed my surgery. So the take-home message for this video is use of a screw type of injector would have prevented this kind of mishap. And don't panic in this kind of situations. Try to react very quickly, position the IOL in the bag, and I had a post-op result of 6.9 for this case. Case number 2, it is a white intermittent cataract. I injected viscoelastic and later followed by a high molecular weight viscoelastic. Then proceeded with opening the capsular bag slowly, and then we had one Argentinian flag sign. So I did not panic. Initially I had panicked, and now I did not panic at this time. I used micro-rexus scissors to cut open, give a nick, and try to complete the rexus from the other side, and then I had the second Argentinian flag sign. So I went ahead with the other side, gave a nick from the other side and tried to complete the rexus from the other side, and slowly I went ahead, but the rexus would not listen to me, and I had the third Argentinian flag sign. Now I went ahead and completed the rexus slowly but carefully. I found out that it was not enough, so I went ahead slowly, tried to open and tried to increase, but the rexus would not listen to me. Now I go ahead and then reduce my phacoemulsification parameters. I was in very low bottle height, about 20 bottle height, 20 IOP, that would be around 27 bottle height. I was going very slow with phacoemulsification, not trying to separate the lenticular or nuclear fragments much, very small, minute separations, then very slow phacoemulsification. I was trying to do it, but it was a very leathery cataract, and very slowly I completed one quadrant. And then went ahead with the other quadrants. All this while I was very careful not to let over my foot pedal from the phacoemulsification foot pedal so that I would not collapse the chamber. And in fact, I had not removed the phacoemulsification probe from the eye for a while. So this is in four times the speed. I went ahead and removed the last instrument. Then before I removed the instrument, I put in viscoelastic and kept the chamber maintained at all times. So I went ahead and implanted a single piece IOL, and the case went fine. So the take-home message is usage of low phacoemulsification parameters and high molecular weight viscoelastics can save you from these kinds of situations. Case 3 is a 14-year-old male who had a trauma, had a corneal tear repair before, and presented to me with this kind of picture. So I went ahead with the surgery, planned the surgery. It was very small areas to enter, and they had a lot of scarring. It's a white intermittent cataract. I planned a very small rexus. To start with, I used a micro-rhexis forceps to start with and try to make a very small rhexis with a plan to increase the size of the rhexis at a later stage. I could complete the rhexis. As this was a young male, I took the incision in the temporal. I sit on the temporal side. Superior, it is not possible to take an incision. I used only irrigation aspiration because it was a young patient. I was in very low bottle height and with very low phacoemulsification parameters, which I will discuss on the next page. And I used irrigation aspiration to complete everything and noticed a small anterior capsular rent. So luckily, this anterior capsular rent did not extend, the trauma did not extend posteriorly. There was no PCR. So I went ahead and injected the single piece IOL. So you notice that by the maneuvering of while inserting the lens, the main incision opened up and extended up to the area of the previous trauma. So and then now I try to increase the size of the rhexis. I give a small nick and try to open it up. So as you know that the main incision has extended towards the place where there was a previous trauma. This was a two-month-old trauma. We had removed the sutures and then planned for the cataract, but still because of the pressure inserted during the lens implantation, the wound opened up, and then now I had to do a suturing and close the wound. As you can see, there is no leakage of the wound, so I had to close the wound. So the take-home message from case 3 is positioning of the main incision. I could have positioned the incision little inferiorly so that this could have prevented this mishap. I was on low parameters, so chamber maintenance is of very importance. As you can see, I was always on 20 IOP, that translates to 27 bottle height, and low vacuum about 100, and aspiration flow rate about 14. I could comfortably complete this case. So this is the post-op day 1 picture of this case. Coming to the case 4, it was a 60-year-old male patient with grade 4 cataract and a 7 millimeter pupil. As you can see, this case was posted for phacoemulsification with femtosecond laser assistance. After I docked the case and completed my capsulotomy, the patient moved and we had a suction loss. So only 1 second of lens fragmentation happened and the machine aborted the case. At this stage, because it is a grade 4 cataract, I still wanted femtofragmentation, but the machine said that it was not possible. So I had to do a little maneuverability and I had to trick the machine. So we entered the parameter once again on a different patient ID, and that went ahead. So the plan was to do, the blue line indicates one phacoemulsification femtorhexis. The red line indicates the another rhexis which is planned again on the same patient, but which is a smaller size. Ideally, a bigger size rhexis should have been correct, but the pupil size is very small, about 7 millimeters. So I had to plan a rhexis on a rhexis. And then the machine would give me pass for a nuclear fragmentation.
A minute more.
Yes. So I went ahead in this way and I could complete, the machine did not give any issues with that and completed the fragmentation. Fragmentation took 35 seconds. So this is the case. As you can see, there is fragmentation has been completed. I dyed it for better visibility. There are 2 rhexises. I try to remove the outer rhexis, and then that completes a small ring-shaped rhexis part. I slowly go ahead and try to remove the entire rhexis. So the rhexis comes out. I open it up to demonstrate. There is a small ring-shaped outer rhexis, which is around 6 millimeters, and there is a central small rhexis, which is around 4.5 millimeters. So I went ahead with phacoemulsification. As you see, it's a dense cataract and the femtofragmentation had happened, so that caused more softening of the nucleus, and I could get ahead with using very less phacoemulsification energy. You can see it is a grade 4 cataract and it is a dense cataract. And I could emulsify the entire nucleus. So the take-home message is double capsulotomies are possible with the femtosecond laser, and this is useful in suction losses. Thank you.
Very nice. Dr. Rupak, just a question. I think it's an add-on.
Sir.
I would say the second case where you had 3 Argentinian flag sign.
Yes.
Did you use the high molecular weight viscosity?
Yes.
Yeah.
Yeah, always use.
One more thing, unless you deepen the chamber, you're going to have again and again the Argentinian flag sign.
Yes.
It is another go-home message for the beginners who are here around.
Yes.
Now we have the next. Thanks a lot.
Thanks.
Now you like to say any comment? Next, I think we'll have number 7, that is Dr. Arvind Kumar Moria. He is going to give us an idea on tips and tricks for management of successful phaco and pseudo-exfoliation syndrome. Over to you, Dr. Arvind.
Good morning, my dear friends, and thank you, AIOS, for giving me the opportunity. So my talk is on tips and tricks for management of successful phaco in pseudo-exfoliation syndrome. So it is known as a disease of Vikings, and it was in 1917 that John Lindbergh first identified this syndrome, and Georgiana Theobald gave this pseudo-exfoliation name to this disease. And the incidence varies 0% in less than 49 and 6.25% in more than 80 years of age group, and it is more commonly seen in the Swedish population. So it is a age-related, genetically determined because of the LOX-L1 gene, environment-related multifactorial systemic disease, and there is deposition of whitish gray pseudo-exfoliation fibrillogranular amyloid-like material in this disease, and it has highest prevalence in Scandinavia and in cold region, but we are seeing all these cases every day in our OPD. So pathogenesis is the jonular weakness because of the proteolytic disintegration, then the poor pupillary dilatation, and the accumulation is at the endothelia, anterior capsule, iris, trabecular meshwork, lens jonules, heart, lung, liver, kidney, meninges, and blood vessels. Other complications are secondary to weakened suspensory ligament. So there is unstable crystalline lens during the surgery, vitreous loss, and nucleus luxation and decentration of the intraocular lens, and secondary to atrophic changes of iris stroma and sphincter. So there are transillumination defects also. And because of secondary to poor blood aqueous barrier, post-op flare and fibrinous reaction are commonly seen. Then secondary open angle glaucoma are also seen in the pseudo-exfoliation syndrome. So these are the surgical implications. So first is the jonular weakness, poor pupillary dilatation, and capsular phimosis. So to tackle poor pupillary dilatation, we can give NSAID after instilling the proparacaine, and during the block, hypertony needs to be there, and choice of IOL, one-piece hydrophobic heparin coated, and IV cannulation needs to be there because sudden hypertony is observed in few of the cases. So for the corneal haze, HPMC 2% can be used, and shallow AC, visco sandwich technique, and post-operative capsular phimosis. So we need to have a larger axis, and non-dilating pupil, of course we need to opt for the iris hooks or rings, floppy iris, again moderate use of viscoelastic, and for jonular weaknesses, step down phaco, direct chop and stop, and CTR and Sione ring needs to be kept ready. Post-op period, multiple and long follow-up is required because capsular phimosis chances are there, decentration of the intraocular lens, and rise of IOP because of the secondary open angle glaucoma. So this was one of the case. So it was a pseudo-exfoliation along with open angle glaucoma. So at 3x3, this scleral incision was given, and depth of half of the depth of this. So I dissect it using the crescent. So you can see how much is the corneal haze. And the trypan blue needs to be pushed under air so that the integrity and the endothelia is saved because of the toxic effect of the trypan blue. Then a axis was made of 5.5 millimeter, and routine hydrodissection and delineation, and stop and chop phaco was done under very low parameters. So at this time you can see there was jonular dialysis as I was aspirating the cortical matter. So CTR was pushed from the opposite quadrant, and then hydrophobic IOL was implanted very gently and very slowly. So in conclusion, cataract surgery in pseudoexfoliation syndrome, although challenging because of weak zonules, compromised endothelia, and poor mydriasis, can be managed with meticulous planning and early detection by the ophthalmologist, and the appropriate management at their center or timely refer to higher centers. Long-term follow-up is required for secondary open-angle glaucoma and to look for the capsular phimosis, and awareness camps regarding this pseudoexfoliation syndrome is a must, and work in tandem with the NGOs for providing care at an economical range and not compromising with the quality care. These are my references. Thank you so very much.
Thanks a lot, Dr. Arvind. Fantastic presentation. Very good tips. Navneet, you would like to share any tips for pseudo-exfoliation? There are a lot of juniors around. He is a teacher, Dr. Navneet Toshniwal.
In pseudo-exfoliation, generally, because of the zonular weakness, we are avoiding the hydrodissection. Completely no hydration, no rotation, and most of the time we have to remove the pieces in situ and just lift out of the bag. That's the mainly trick to avoid the zonular. Still more weakness.
Dr. Mohanta, sir,
Thanks,
would like to comment?
Is Dr. Mohanta? Yeah. Mohanta, sir.
Pseudo-exfoliation.
Hello.
Phaco in pseudo-exfoliation.
He is one of the most high-volume surgeons on YouTube.
Okay.
He was a very good teacher and a scientific committee member. Yes, sir, over to you.
Yeah. In pseudoexfoliation, there can be people can be small. In those cases, pupil expansion devices should be used, either iris hook or PX, whatever is the surgeon comfortable with. And then rexis, if the zonule is weak, we cannot do a large rexis because then there can if it goes into the zonule, then it becomes difficult. Moderate about 5 mm rexis, and hydrodissection I do, and I rotate the nucleus bimanually, not with just pushing with on hook. Bimanual rotation I do, and it helps in those cases.
Thank you, sir. Thank you so very much.
Thank you, Arvind. Dr. Mohanta also thanks, and Dr. Navneet. We have the next case coming up. It's our convener, Dr. P. Shweta. She is going to speak on phaco in small pupil without any devices. Yeah, over to you.
Good morning, everyone. So today my topic is phaco in small pupil without devices. So there are a plethora of devices available in the market, as you all know. But when would you want to perform phaco in a small pupil without devices? Either when there is a non-availability of devices or due to cost factor, or when the pupil is not very small and you don't want to use a mechanical device because every device causes some amount of sphincter damage. So small pupil is defined as a pupil size of less than 6 millimeters. So what are the risk factors? Pseudoexfoliation, diabetes, chronic uveitis, trauma, prior ocular surgery, prolonged use of myotics like pilocarpine, floppy iris, high hypermetropia, and so on. So the complications include damage to the sphincter, iris shaffing, PC rend, nucleus drop, and also because of the prolonged surgical time, there can be AC inflammation, endothelial damage, and so on. So the difficulties associated, all the steps become difficult because there is a difficulty in visualization because of the decreased red glow, and also there is a decreased working space because of which there is difficulty in maneuvering. So the outcome depends upon the biomechanical properties of the pupil, that is whether the pupil is, the iris is floppy or not. So if it is a floppy iris and the pupil size is less than 4 millimeters, it is better to go with a device in the first place because the pupil size tends to come down further while performing the surgery. Again, the density of the cataract, that is very hard and very soft cataracts, can be difficult to manage in small pupils. And also the surgeon's experience matters. So preoperatively, do a thorough slit lamp examination and rule out comorbidities like shallow anterior chamber, corneal guttae, or any corneal opacity. So we tend to give NSA drops like bromphanac 3 days prior to surgery because it helps in dilatation, and also use tropicamide plus prior to the surgery. Intraoperatively, you can use pharmacological agents like adrenaline, either intracamerally or you can mix it in the irrigating solution. And nowadays we have newer fixed dose combinations like phenocaine plus, which is supposed to provide sustained dilatation throughout the surgery, but I really don't have experience with that. So before doing a dilatation, it's important that you it's not playing. Yeah. So always remove the synechiae before proceeding with the surgery. So this is a case of angle closure glaucoma with a history of prior trabeculectomy. As you can see, the synechiae are being released under irrigating solution, because once you inject visco, as you all know, the staining of the capsule will not take place. Viscomydriasis. So always use a viscoelastic agent like Helon 5 because it will give you another additional 1 to 2 mm of dilatation. And also you can use a viscodispersive like visco to coat the endothelium using the soft shell technique. Next, capsulorhexis. So capsulorhexis, always use trypan blue to stain the capsule, especially if you're a beginner, because there is already a decrease in the red glow, and it will help you in the completion of the rhexis and the visualization. So the size, this is a case of brown cataract. So this is a case of brown cataract, and here you can see the rhexis is being performed with an Utrata forceps, and always aim that the size of the capsulorhexis should be equal to or slightly larger than the pupillary size. Coming to hydrodissection, always perform a gentle hydrodissection, because if you inject a large wave of fluid, it tends to irritate the iris. Yeah. Thank you. Tends to irritate the iris, and that will cause further constriction of the pupil. So inject multiple small waves of fluid in several quadrants and look for forward movement of the nucleus to ensure a hydrodissection has been done. Next, coming to phacoemulsification, this is a case of mature cataract with around 5 mm of dilatation. And if you're a beginner, it is always better to perform the surgery under a peribulbar block. As you can see, there is a central trench which is done, and the nucleus is being chopped by vertical chop into several smaller fragments. And it is important that you stay in the center of the pupil, and before emulsifying the fragment is always brought to the center, because that is where there is maximal working space. And the parameters can be more or less maintained like a regular cataract as long as the iris is not floppy, because in a floppy iris you will have to decrease the parameters. This is a case of So this is a case of brown cataract with around 4 mm of dilatation. And here a central crack is being made using a modified stop and chop technique. And the nucleus is further divided into smaller fragments using a horizontal chop. And the basic rule remains the same: make it into as many smaller pieces as possible, and always bring the fragment into the center before emulsifying it. Next, this is a case of floppy iris.
A minute there, huh?
Done. So this is a case of floppy iris. Here the wound construction is very important, because already the iris tends to prolapse throughout the case, and you have to take parameters slightly at the lower level, because there will be a lot of turbulence in the anterior chamber and the tissue tends to come towards the phaco probe. And in case the dilatation comes down midway through the surgery, you can always inject a viscoelastic through the side port for further dilatation. And in case the dilatation does not increase when you inject a viscoelastic, you can always use a dilating device. So cortex aspiration, it's always better to use a bimanual irrigation and aspiration system because you will be able to lift the iris to visualize the cortex, and that will ensure a complete removal of the cortex. Coming to IOL implantation, always make sure that the leading probe goes into the bag, leading haptic goes into the bag so that you ensure an in-the-bag placement of the IOL. Visco wash, thorough visco wash should always be performed because a lot of visco tends to be trapped behind the iris because of the small pupillary size, and also the visco behind the IOL has to be removed. So conclusion, safe surgery is always the priority and don't hesitate to use devices when needed. Thank you.
Very nicely depicted. A small tip for those who have just seen how she's doing with the forceps. Don't press the posterior lip, otherwise there will be egress of the viscoelastic, the shallowing of the anterior chamber, and there will be a run through. Next we have, any questions you have for Dr. Shweta? We move to the next otherwise. Yeah. The next one is phacoemulsification where small becomes tough. I think Dr. Jani Basha Sheikh. Is he there? Over to you.
Good morning, everyone. My name is Dr. Jani Basha. I am from Sankanetra Chikitsalaya, Vijayawada. Nowadays, we encounter many cataract surgeries patients with small people make the surgery significantly more challenging. If people then dilate insufficiently, we can achieve about 5 mm pupil and 5 mm capsulorhexis. The surgery will be smoother and safer for the patient and also less stressful for us. If we get small people, what we do? If we go for small incision or we go for phacoemulsification. Then if you prefer phacoemulsification, then we have strategic approach for the small people. Then firstly, we go with pharmacological agents and then viscomydriasis. Then after that, pupil mechanical stretching, and last one is hooks or rings. In pharmacological agents, we can use midricaine or epinephrine or some trade names, that Phacoemulsification plus or everything. This is the small video. We use adrenaline drops, adrenaline intracamerally. Then pupil is slowly dilating. It achieving around 5 mm dilatation. We are very happy with the dilatation. We can go for surgery for safe. And also viscomydriasis, the OBD is mainly heel-on type, and it pushed the iris outwards and expand the pupil, but it was short-lived. If in any mid-size pupils, around 3 to 4 mm pupils, it doesn't require that iris hooks or expansion devices. We can use anesthetic drops and agents. We put OVD, it will give around 1 to 2 mm dilatation. Then it will be sufficient for do surgery. And also another one is if viscomydriasis fails, then go for pupillary stretching. This is mechanical stretching. It causes micro tears and sphincters, but it allows the greater dilatation. We can use 2 or 3, 4 prongs or Y hooks or and Kuglen hooks. But it better to avoid in rubeosis iris, chronic uveitis cases, and coagulopathies. It may cause bleeding and floppy iris. This is the another video. The case of post-uveitic cataract, but mechanically I remove the adhesions beneath the iris. After that, I make 2 side ports on either side. With the help of the, I put visco. Then with the help of the Y hooks on both sides from opposite sides, I engage the Y hooks in the pupillary margin. it stretch opposite direction. Then again this maneuver, we switch the instruments at 90 degrees, then do on other side also. It give reliably around 4 mm, 4 to 5 mm, 4.5 mm dilatation. After that, we can try viscometriasis also. Then we go for surgery. This is another. This is the another case. So multiple adhesions. Syneque is there. I put more visco, and with the help of the iris spatula, I break down all the adhesions. And then if stretching also fails, then pupil expansion device as in like iris hooks or pupil expanding rings are useful in very myotic pupils. These devices must be inserted gently and atraumatically as possible to avoid damage to the iris. Too much manipulation, it can lead to the postoperative inflammation, and it will takes longer to recovery. Is a case of small people, then with the iris hooks. This one is I just it give good amount of dilatation. And also this one in the hooks we give lot of side port incisions, but in rings from the main port we insert the ring also. In I am less familiar with Bhattacharya ring, but I am using regularly this Gupta ring with the upper cartridge. We can insert easily. Before the inserting, we put more visco beneath the iris also. Then with the help of the Sinski hook and iris repositor, then we engage the 4 prongs with iris sphincter. Then rotate gently. Then again visco. After incision, it may be slightly decentered, make it center, and then do surgery. This is another small people. In small people, we can go with low parameters. Don't increase bottle height. It doesn't push the iris lens diaphragm downwards. It can cause iris into the iris prolapse into the side ports and everything. So make it low parameters, and also in IOL in the IOL biometry, it gives the lens thickness also. Then according to that thickness, make a good trench. With the help of the good trench, with great vacuum, then with the help of the chopper, then make a separation. Take home message. The cataract surgery is the in the presence of small pupil one, it is more difficult and challenging ophthalmic procedure. The pupil expanding devices aid as an alternative to manage in a case of small pupil, but keep in mind about complications like iris sphincter and tear, bleeding and damage, and fibrinol necrosis, fibrin reaction. Minimally invasive procedures reduce surgical trauma and complications and provide best visual and anatomical outcomes. Thank you.
Thanks, Dr. Sheikh. Just a small tip I would like to share with you people is while you was putting the iris hooks, try and be equidistant your side ports.
Yeah,
Otherwise,
just
you
a
have to use one more.
Yeah.
So you can save one iris hook. Thanks a lot. Over to you, Shweta.
The next speaker is Dr. Kiran Kumar, cataract.
Can you please take the mic, please, because we have not heard your questions. Yeah.
How do you plan the main incision when we are planning iris hooks? Like in between the hooks or nearer to one hook?
Generally, I prefer temporal section, sir. In the temporal, opposite to the temporal section, one will be there. After that, near to incision, another one is there. So it will be easy for us to just suppress the iris, don't come out from the main port.
Thanks. Any more questions? We shift to the next talk, please.
The next speaker is Dr. Kiran Kumar, cataract and zonular weakness.
Thank you very much. Thank you very much, AIOS, for giving me this opportunity. Zonules are thread-like structures that connect lens to the ciliary body. They are present 360 degrees all around. If there is no zonules, lens will fall into the vitreous. The main causes of zonular weakness in our clinical practice is one is pseudo-exfoliation, another one is trauma. Then in trauma, we get not only zonular weakness, there are multiple other associated anterior segment and posterior segment features. We have to take care of those things. Lens-induced glaucoma, both phacolytic and phacoemulsified glaucoma, hypermature cataract, and hard brown cataract where the lens thickness is very much high. In these cases, there will be a zonular weakness. The lens and iris coloboma, spirophakia. Spirophakia is generally a bilateral condition in which zonules are very much seen after dilatation of the pupil. Other main causes of zonular weakness, what we see in clinical practice is glaucoma, Marfan syndrome, Will-Marchesani syndrome, homocystinemia, iridocyclitis, retinitis pigmentosa, and after a pars plana vitrectomy, intraocular surgeries like trabeculectomy, high myopes, and very old age. In all these cases, there is a chance of zonular weakness. And we have to look for preoperatively whether there is zonular weakness is there or not in every case. The main preoperative features are, one is phacodonesis, another one is if the lens is displaced a little bit posteriorly, iridodonesis will also be seen, and subluxation and dislocation of lens, which will be seen mostly undilated people. We miss these things, and if you only after dilatation only we can see the subluxation or dislocation of the lens. Other associated features are low endothelial corneal count and irregular AC. That means either it means a shallow or it is a deep or it is irregular. If the lens is a little bit posteriorly displaced because of weak zonules, in such cases AC will be deep. And if there is a phacoemulsified glaucoma, in those cases the shallow AC will be there. If there is a trauma, at one part the lens will be tilted. At one part it is a deep and at one part shallow, that is irregular AC, and there are small people. Although in all these features, if you see all these features, we have to suspect a zonular weakness behind. Intraoperatively, when we try to do the capsulorhexis, the capsule will not tear. Instead of tearing, it will fold on itself. This is the main sign we have to note there is a zonular weakness and we have to take care of. And there will, in zonular weakness cases, there will be a difficulty in nucleus rotation because the zonules will stretch, will fumble. It will not, if the zonules are taut, nucleus will easily rotate. If the threads are loose, it will not rotate. Nucleus rotation will be difficult. And cortex aspiration is very difficult, although Phaco itself is difficult. After Phaco over uneventfully, even cortex aspiration is much more difficult because aspiration port will try to catch the anterior rim of the capsule. Then if you drag it, then there will be jonular dialysis. IOL implantation is very difficult, especially if the pupil size, rexis size is small, because weak jonules, during IOL implantation also, there is a chance of jonular loss. That means at each and every step of phaco surgery, starting from capsulorhexis to the implantation of IOL, there is a chance of jonular damage in these cases of weak jonules, in all the cases which we have already seen for. While doing surgery, what we have to keep in mind is, one is whether the jonular weakness is focal, that is limited to a few clock hours, that is a 2 clock hours, 3 clock hours, or much more than that, or it is global, all over the jonules, all jonules, like pseudo exfoliation, all jonules are weak. That we have to keep in mind. If there is a trauma case, if the focal loss or focal weakness of jonules, how many clock hours and what is the location, superior, inferior, temporal, and nasal? Because inferior jonules, if they are very weak, the chances of difficult surgery and post-operative decentration of IOL is much higher when compared to superior, because this is because of gravity. So we had always keeping our incision, phaco incision, and also putting IOL, we had to keep these things in mind. How to tackle during surgery? Rexis forceps, normally many people we do with the 26 gauge bent needle cystitome, but in these weak jonules, Rexis forceps, either Haldipurkar forceps, Inumera forceps, retinal microceps forceps, or whatever, that gives much control over Rexis. And capsule hooks are very useful in these cases in the way when the jonules are very weak. CTR and CTS are also useful. And when to insert a CTR, when to insert a CTS, it depends upon the surgery, because where the surgery goes difficult. At that step, we only will put a CTR. These are the instruments. If you are tackling with a weak jonules, these are the instruments we have to kept ready with the regular cataract surgery, because these things we don't keep ready, because in a normal case we don't keep this one. So these things has to be kept with Rexis forceps, CTR, CTS, capsule rings, all these things should be kept ready. And this is in weak jonules, there is a hole in the CTR that could be tied to the scleral fixation. That can be scleral fixation. This is we created a scleral pocket here, and these CTRs can be sutured to the sclera, so it won't. The jonules will be much better stabilized. All weak jonules are always associated with some other factors like small pupils. So in such cases, we have to use small pupil expanders, like previous surgeons showed that iris hooks and rings, Malyogan ring or BHEX ring, whatever it may be, and good endothelial protection, because pseudo exfoliation like cases and trauma cases are always associated with a low endothelial count. So good viscoelastics containing sodium hyaluronate and chondroitin sulfate is very good option in these cases. And there are different thoughts of how to do a Rexis. The small Rexis are normal size 5 to 5.5 mm is
1 minute more.
Good. But some people thought that some school of thought is the large Rexis is good. Avoid excessive hydrodissection, and don't start the hydrodissection at the weak jonual spot where the jonular nucleus drop will happen. So always start the hydrodissection at where the jonules are very strong. And during phaco also, we should not pressurize much to the posterior, that is on the lens. So it's a direct chop. Instead of trenching, the direct chop technique is very good in these cases. And cortex aspiration, there is already, we have told, that the chance of jonular dialysis, here aspiration port dragging the capsule, and then jonular dialysis is happening. So always keep ready these two things. One is anterior vitrectomy. We have to keep in mind there is always chance of vitreous loss in these cases because of jonular dialysis. We have to keep that in mind. And if there is a nucleus drop, post-planar vitrectomy should be kept ready. IOLs, there is a 3-piece hydrophobic foldable IOL. That is haptics in the sulcus, optic capturing in the bag is a good option. And single-piece hydrophobic foldable IOLs are also good. Hydrophilic IOLs, yes, there is a capsular phimosis. SACS is particularly very good in this section, and iris claw IOL, SFOL, ACIOL, if there is total zonal loss, we have to keep it in mind. So zonulopathy is not uncommon. Capsule hooks, CTR, and pupil expanders has to be ready in the OT, and direct chop phaco is the technique of choice, and hydrophobic 3-piece or single-piece hydrophobic are good. SACS PMMA IOL is very good option, and vitrectomy should be backup. And in case of total zonular loss, if there is ICCE, iris claw, scleral fixation, ACIOL should be kept ready. Thank you very much.
Very nicely covered, Dr. Kiran Kumar. A small tip I would like to share. Whenever there is zonular dehiscence, in that area you do the cortical aspiration last. Because if once you pull it and it goes off, rest of the cortex remains. So try and finish off all that and then you access the last. Anyway, thanks a lot.
Thank
Challenges in cataract surgery in anterior lenticonus, Dr. Pankaj Dogre.
This is on. Yeah. Yeah. Good morning, everyone. So the topic for my presentation is challenges in cataract surgery in Alport syndrome. Yeah. So these are the abbreviations which I have used in my presentation. So the objectives of my presentation is to discuss the ocular and systemic manifestations of Alport syndrome and to elucidate the different challenges in making the capsulorhexis in cases of anterior and posterior lenticonus. So this was a patient who was from Srikakulam, a student of 24 years old. He came to us with a diminution of vision in the left eye, which was gradual, painless and progressive. He had history of right eye cataract surgery done 15 years ago, and also he has recent onset of hearing loss. The family history was not significant. His refraction in the right eye was 2500 with and it was improving to 20/20 with this correction, whereas left eye vision was not improving. On slit lamp examination, the anterior segment and posterior segment of the right eye was within normal limits, except he was having the posterior chamber IOL in the right eye, whereas in the left eye he was having anterior lenticonus. This is the slit lamp image which shows that there is bulging of the anterior lens capsule in the center. We performed OCT macula in both the eyes, and what we have seen is there was temporal thinning on both the eyes. The temporal retina was thinned out. So with these findings we came to a diagnosis of Alport syndrome. So coming to the history of Alport syndrome, it was Dr. Cecil Alport who in 1927 described the Alport syndrome in a family members who had hematuria, uremia and deafness. So as we know, the Alport syndrome, the basic pathology lies in the type 4 collagen, and this type 4 collagen involves alpha 1, alpha 2 chains in the basement membranes, and these membranes are especially present in the glomerulus, ears and eyes. So these three structures are mainly affected in Alport syndrome. So as these three structures are affected, we will have renal, auditory and ocular manifestations. The renal manifestation includes the hematuria due to the endothelial cells of the glomerulus are affected, and the space between the endothelial cells increases. Even the auditory, the organ of Corti also has the basement membrane, which also involved in the Alport syndrome, leading to sensory neural hearing loss. The ocular manifestation, it involves the cornea, the lens and the retina. In cornea we can see dystrophy like posterior polymorphous corneal dystrophy, which can be vesicular type and can be band shaped. In the lens we can see either anterior lenticonus or the posterior lenticonus. We will get a oil droplet sign in retinoscopy in these patients. The renal manifestations can be temporal thinning of the retina, which can be seen on OCT, or there can be giant macular holes. So coming back to our patient who has anterior lenticonus in the left eye, after clearance from the nephrologist, we went ahead and did the phacoemulsification in the left eye. Unfortunately, the video is not available. At 5 weeks, the patient had visual acuity of 20/20 with +2 diopter sphere. And coming to my second objective is to elucidate the different the challenges in performing the continuous curvilinear capsulorhexis in presence of anterior and posterior lenticonus. So as there is bulging of the anterior lens capsule, to start the rhexis, if we start the rhexis at the center, the rhexis will run away. So the tip is always start your rhexis beyond the cone, and try to involve the cone in your flap of the rhexis if you are doing the rhexis manually. But if you have other devices like Zepto precision pulse capsulotomy, or you have femto laser available, then you can do a capsulorhexis along with these devices, and you can include the cone at the center of while docking in the with the femto. So this was a paper where they have published, they have done one eye with Zepto and the other eye with femto in patients of anterior lenticonus. So there are multiple case reports and papers where they have used femto laser assisted cataract surgery in performing the anterior capsulorhexis in these patients. In pediatric patient especially, they also have the posterior lenticonus. So in posterior lenticonus also, in pediatric patients we do posterior capsulorhexis. So doing posterior capsulorhexis is also difficult in these patients, but if we do meticulously, as we have to do anterior vitrectomy in these patients, if we do meticulously, even posterior capsulorhexis can be done. Yeah, thank you.
Very nicely covered. Any questions? It's a very nicely depicted case. Of course, he could not share the video, otherwise it would have been icing on the cake. Anyway, thanks a lot. We have Dr. Navneet Toshniwal. He is a teacher of teachers. He's written 2 books on phacoemulsification. Today he is going to discuss happenings in phaco surgery. Over to you, Navneet.
Thank you, Jignesh. Respected chairperson, co-chairperson and colleagues. This is a very simple topic, that is a happening in phaco surgery. If you really record your each and every case, in every case there is a something will happen which you don't know. And I always stress this, record your every case and then you will get. I have a collection of around 500 cases around. Something different thing has happened. We will see some of those. This is we have listened the topic of zonular weakness. This is the very good instrument, Toshniwal microcapsulorhexis forceps here in Sunena Surgical. Although we are using the good forceps also, you can see the 2 bands has been stretched out. And this is normal thing. Now what to do at that point? Take the point which is closer, and here the speed is very important. That one jerk to correct the capsulorhexis. So it is the speed of capsulorhexis which is needed at this particular point. If you will go slowly, it will run away. Now in this case particularly, you can see the cortical cataract at one zone. And before surgery, I thought that there may be some zonular weakness, can be there. I don't know, it may be micro. And then I notice here you can see that bluish discoloration, trypan blue has gone behind the vitreous. And now the things are different. Here you have to take all the precaution as if you are doing a case of zonular weakness. So all the things are ready. This is the microcapsulorhexis forceps, very unique design instrument. I have already mentioned with the Sunena Surgical here. And then I don't do hydro. Believe me, this is not a very good platform to say. Last 15 to 20 years, I have stopped hydro. I don't do rotation, I do no hydro, and directly start the trench in the center. This is stop and chop technique. And then with the another new design instrument, this is the pre-chopper,
I just divide the nucleus into two pieces, equal half. Although there is a zonular pressure weakness, there is a equal pressure, so it will not get damaged still more. Then lift out one piece out. You can directly chop it at the level of rhexis if nucleus is not very big, or you can chop in one or two pieces, but the level of capsulorhexis plane or just supracapsular plane. All the things are in my mind that there may be some dehiscence in the zonules, where exactly I don't know. So intra-bag manipulation, you have to be very careful. See, I am not rotating, just lifting other half, and already I mentioned with the good cutting machine, this is at a very nice plane. And now you can see, now this is the empty bag without nucleus. You can see clear cut. Something is behind. Bimanual is ideal, but I generally use the coaxial irrigation aspiration. This is also very unique 45-degree angle from MST, USA. Very unique design instrument I am using from 20 years. It's absolutely no problem. But you have to take precaution everywhere. Each quadrant slowly, little bit pull, go in the center, little bit pull, go in the center. And still I was in dilemma that what is going to happen, I don't know. And this is what I try to mention, that anything can happen during the surgery. You should know the clear-cut concept. You should have the clear-cut idea. Now sub-incisional cortex is difficult. Try to do it. Otherwise, leave it, put the IOL, and then remove afterward. That's very simple. I have put the lens, and now one interesting point, when I started the aspiration of the viscoelastic, I found that trypan blue color dilutes or something, whatever thing has gone behind. I was just aspirating the things, and there was a dilution of this trypan blue. Otherwise also, this trypan blue, in 1 or 2 days, it will you will not get a severe reaction or like that. This is the generally. And last night when I was doing removal pieces, something as plastic was there. I have removing with this micro forceps, and that's all. So this is the way, there are many things can happen. You should be ready with these things. And when it's not a high volume surgery, it is whatever you do, you should be ready with the things, and anything can happen. My sincere appeal is record your cases, each and every case. You will get the new point every day, and you can learn by your videos. Thank you. Thank you for
Very
your
nice,
precious time.
Navneet. Just 2 or 3 questions, as you are writing books on Phaco for the beginners. What are your Phaco parameters for a standard cataract surgery?
See, ideally in Phaco 1, during the trench, energy is most important. Vacuum and flow rate should be less. For Phaco 2, hold and chop, vacuum is the most important. Flow rate just to pull the piece. So vacuum in a panel mode, around 300 millimeters of mercury in a routine cases, flow rate 25 to 30. And when you are removing the pieces, if you are in a panel mode, you have to be careful when you are putting your Phaco tip periphery. So if it is linear mode, vacuum and flow rate, you can easily manage. No problem. But if you want to take your pieces quickly out and all that, so that is the Phaco fluidics. That is very important. At that time, if you keep the flow rate in a panel mode, decrease the parameter. Maybe 28, 20, 30 like that. It should be in a control band. Many factors are there. Chamber depth, how many instrument, how many incision you are using. So these are the other factors for Phaco fluidics.
Do you use the epinuclear mode while you finish all the things?
Yeah, last pieces, especially epinuclear mode, immediately you should go. As a routine, you should go. And I try to avoid removal of the epinucleus with the Phaco tip. If it is a bulky mass, it is indicated to remove with the Phaco tip, then remove. Otherwise, irrigation aspiration for the epinucleus.
What is the parameter for epinuclear modes?
Generally 15 to 20 flow rate and 300 around vacuum. This is the general parameter.
Perfect. Thank you very much. Any questions anybody has? He can always utilize his good services. He's a teacher of teachers.
I will
Any
just
questions you have, please let us
take
know.
the opportunity. I have written 4 books in phacosurgery, simplified phacoemulsification, how to see the patient on slit lamp before surgery. Third book is do's and don'ts, and fourth book is very unique book. It is on a phaco machine. It is only 75 pages book. I think everybody should have, and you should add more points in that. Thank you.
Thanks, Navneet. Next we have is tips and tricks, Dr. Arun. Polls to a daily routine scenario, cataract surgery in glaucoma patients, Ravi Chandra K. There you are, sir. Over to you.
Good morning, everyone. Today I will be speaking about pearls to a daily routine scenario, cataract surgery in glaucoma patients. The next 7 minutes I will be covering these topics. It's not moving. Yeah. Coming to the introduction part, cataract surgery is a valuable adjunctive treatment for glaucoma. In case of angle closure glaucoma and in case of ocular hypertension, it itself acts to the reduction of IOP. It also opens up the possibility of combining the cataract surgery with a MIGS procedure in case of mild to moderate cases. However, selecting a lens implant and performing cataract surgery in glaucoma patients may not be as straightforward when compared to that of a normal eye. With this background, first I will go to the patient selection criteria. Always in case of a glaucoma patient, always less is more. Means the lesser the disease, the more is a chance of successful outcome. So we get a better outcome milder cases. This is because you are not competing with other levels of impairment. So the patients with ocular hypertension, glaucoma suspects, or those with very mild pre-perimetric glaucoma are going to be the great candidates if they are also well controlled and the visual fields have minimal peripheral defects. So these will be the best candidates to try out any premium IOLs like multifocals or extended depth of focal IOLs. However, coming to the poor candidates, these include patients with advanced disease, any kind of central field defect, poorly controlled disease, or at high risk of progression. So these are the patients who will have the least level of successful outcome, and these patients usually require trabeculectomy or tube shunt procedure, and they don't do well with the premium IOLs because of the astigmatism that is induced by these procedures. Coming to the ocular surface health, which is very important in case of glaucoma patients because they are using long-term anti-glaucoma medications, ocular surface health is usually compromised, and you have to use artificial tears for a longer period of time, medications such as immunomodulators, removing excess lid debris, or treating the meibomian glands. This is particularly important because meibomian gland disease can lead to an unstable tear film, fluctuating vision, and inaccurate biometry and topography, which may even lead to improper IOL selection. So, in addition to recommending the lubricants, lid hygiene measures, vitamins and warm compressions or heat applications for long-term care, a short-term dose of oral antibiotics like azithromycin may help in meibomian gland dysfunction. So, we have to clearly communicate to the patient that this meibomian gland disease, ocular surface health has to be taken care even after the procedure is completed. Coming to the setting up the expectations, always you have to clearly communicate with the patient about the expectations and always keep the expectations at a lesser level. And we have to take visual field, the patient's recent visual field, at least 3 months old duration has to be taken, and patient has to be explained about all the aspects like blind spot, gray spots, what natural blind spots from glaucoma, and which are the areas which are affected or not. So we have to clearly inform the patient that a light gray area on the visual field is where you can expect enhanced vision, but any dark area or black areas are permanently damaged spots and vision can't be restored in such areas. So patient need to have an understanding of their glaucoma so that they can understand that after the surgery, when the cataract is gone, what is left over is their glaucoma. And better to set the expectation before the surgery as opposed to having them wonder why they are not seeing better. And some patients even think that the cataract surgery is going to cure their glaucoma also. So we have to clearly communicate with the patient about these things. Coming to the IOL selection, which is an important part, cataract surgery improves the vision even in severe cases, but what will not be improved after the surgery will be the lost contrast sensitivity and the visual field defects which are already gone because of the glaucoma. So factors that have to be considered while choosing an IOL implant will be the age of the patient is the first thing, because we have to be more conscious in case of younger individuals because they have higher risk of progressing when compared to an older individual. the severity of the disease, the number of medications they are on, and the state of their ocular surface. So monofocals are the safest choice for patients with pre-existing ocular pathology. This is because these monofocal IOLs do not split the light. So patients with ocular hypertension and those with very early stable glaucoma can benefit when from the other type of premium IOLs or the refractive IOLs. So even in such patients, better to be on the conservative side, and we always recommend an extended depth of focus lens like a VVT or Symphony if a mild glaucoma patient is desired little more range of vision. And always try to communicate with the patient about the possibility that future disease progression could render these refractive options less useful. And for a moderate to severe patient, always lean towards a monofocal. This is because once the patient has a certain amount of loss of contrast sensitivity, they will be more likely to notice any drop off in vision when compared to with a premium lens when compared to that of a non-premium lens. And aspheric IOLs have the ability to reduce the contrast sensitivity to a lesser level. Always better opt for a aspheric IOL. And Eyhance or VVD lenses, which are extended depth of focus lens with offered enhanced intermediate vision, or the light adjustable lenses would be a good option for such glaucoma patients. Then if you are going for a toric IOL, then since these IOLs don't split the light, they can give good vision to the glaucoma patient who want to correct their astigmatism also. But two important considerations have to be considered when considering a toric IOL in such patients. The first thing is the zonular weakness, particularly in case of pseudo-exfoliative patients. Because of the potential for decentered IOL, this always better to opt for a capsular tension ring for extra stabilization. And the second thing is never combine a toric IOL with a trabeculectomy or tube shunt procedure. This is because of the astigmatism induced with these procedures. There may not be the correction of the astigmatism may not be satisfactory. So always give the patient at least about 6 months or more to have a stable refraction and then do the cataract surgery. And always prefer aspheric toric IOLs because they are effective in reducing the astigmatism induced by previous surgeries. Coming to the role of multifocal and EDOF IOLs, yes, there is a role of these in glaucoma patients, but only with certain caveats. The first thing is mild, moderate, and borderline severe cases, depending on where the defect is, we have to opt for these lenses. If the patient has advanced field loss with only central island of vision left, they have so much loss of contrast sensitivity already from their glaucoma, it is not a good option to go for these lenses in such patients. Always patients with superior arcuate defects and clear inferior hemifields, multifocal and EDOF IOLs can be used. And EDOF IOLs like Symphony lens are preferred over trifocal IOLs as they cause lesser contrast sensitivity reduction. So the pearls for successive cataract surgery in glaucoma patients include always clear the pass using iris stretching procedures, better to use iris hooks than the rings, always add goniosynecholosis to your surgery, and in case of pseudo-exfoliation patients, go for a supracapsular tilt because of the less stress on the zonules. Always leave the eye firm in patient with previous trabeculectomy to avoid hypotonia and bleeding post-operatively. And consider doing MIGS at the beginning of the case. Usually it is preferred to do at the end of the case, but beginning of the case if we do, there will be good chamber stability and minimal bleeding and lesser need for use of viscoelastics. Consider shortening the tube if there is an issue, and use a higher steroid regimen in filtering blebs. Post-operative steroids IOP monitoring is very important, and always ask the patient to continue the glaucoma medications in the early post-operative period so as to avoid a post-operative spike. More frequent follow-up, particularly mixed with MIGS procedures, and in goniotomy procedures, hyphemas have to be treated aggressively. To summarize, selecting an IOL implant and performing cataract surgery is not straightforward. Patient selection and selected patient is very important. Treating ocular surface disease is very important. IOL selection plays a very important role, and always the surgical technique has to be customized according to the patient's condition. Thank you.
Fantastic. Very nicely covered this topic. I'd just like to ask you a question. If it in moderate and advanced cases, do you plan to do simultaneous trabeculectomy or shunt and phacoemulsification, or you try to defer it, and what is the reason for that? Please explain that.
Depending on the level of field depression, sir.
Yes.
So if it is going to the macular split mode or anything, always try to do a glaucoma procedure earlier and try to do a cataract procedure later.
How much gap do you give in between?
2 or 3 months, sir.
Perfect. Very nice.
Thank you, sir.
Any other questions you'd like to clarify? Otherwise, we are through with the session. We'll have a group photograph. All the speakers and the chairpersons can join. Somebody to help us take a photograph. and the next session can take over. Thank you very much. I, on behalf of the chairpersons, thank the AIOS Chairman Scientific Committee, Dr. Namrata Sharma, and her team to give us a chance to be the chairpersons for this important session.
Thank you to the local organizing committee also for giving us this opportunity.